Next we have Dr. Dan Chung, who is our Director of Outcome Measures on clinical trial development. And Dan is trained as a pediatric ophthalmologist, and we're lucky to have him here today.
Well, thanks, Jean. Thanks for having me a part of this panel. It's always exciting being up here, and being a part of this work really is a highlight of ophthalmology for me. So I just wanted to give you a very brief chat about the primary outcome measure and how it came to be in our study. So one of the challenging things about new therapies is that you have to match the outcome measure to really capture what is being done with this potential new therapy. So this is one of the challenges that we face when we are going for USA licensure, especially for a product that involves low vision subjects. So we're all very familiar with the concept of visual function. Basically a need for something that is clinically meaningful. And in the past, we've been used to that standard of 2 lines of improvement on the ETDRS chart, and in some instances, use of visual fields and improvements in that. But one of those issues is that for the populations of low vision subjects, which obviously LCA is part of, and those that are even ultra low, those 2 parameters may not be overly relevant in measuring their therapeutic effect. So one of the things we then look at is another concept called functional vision. And this is where we can determine how their newly acquired vision would be meaningful to them as they go through issues of daily life. Things such as light sensitivity, dark adaptation, contrast, and navigation. So one of the issues with this, however, is that clinical meaningfulness has really not been established as of yet. So one of the things that the team has come up with is this concept of a mobility test, and it's a measure of functional vision. And it's gone through several iterations, as you've seen with Jean's earlier talk. For the phase 3 study, we felt that there were a few things that we needed to modify, and one was we need to update our SOP, our standard operating procedure. It is quite detailed, and we also wanted to make sure that things were reproducible and standardized. So we went out and we designed 12 distinct courses, and they were pre-printed, no longer on separate individual tiles, but on large sheets. And each course was then standardized to the number of turns, the number of tiles with arrows, and the number of obstacles that they would encounter. And because room lighting, and lighting is such a significant factor in labors, that we wanted to make sure that the lights were also standardized. And so the lights in the room are measured at 7 different levels prior to administering the test, and obviously those are done by calibrated light meters. We also had to do some electronics modification because some of the light levels are extremely low. And so we had to go to specialized or high-end DSLR cameras that take a video at very, very low light levels, as well as using ultra-wide-angle lenses. So that was the physical makeup of the course. Well, any new test has to be validated. So we went about going and doing a validation test, which is still in progress as we speak. So some of the things that we need to look for is this clinically meaningful? So in this study, there were 2 arms of it. Basically, subjects came in for a baseline visit, 2 baseline visits actually, to make sure that there was good reproducibility and stability, and then coming back in a year, and to really gauge what kind of changes that we may see. So one group was those that had visual impairment, and we varied the genotype. And one of the questions was which genotypes would actually be good for this type of test. And obviously, we felt that individuals with mutations in RP65 were one of those. We also wanted to see if this mobility assay would help us gauge and capture disease progression as well. The other arm was those of controls, or those that had no visual impairments. And we were looking to make sure that they had no changes over a year, that they had good stability and there was good reproducibility. And in preliminary results, we are finding that all to be so. To take any bias out, obviously we send these to masked graders. And those were also analyzed for inter and intra-grader variability. And we found that in preliminary results so far, that is also looking quite favorable. And then the courses themselves. Are there any major differences in the courses, the way we designed? Is one easier? Is one more difficult? And we found that there's good agreement along all those courses. And then eventually, and concurrently, I should say, we are looking at the ability to correlate the results of mobility testing as well as all the other tests that we do to evaluate visual function and functional vision. So one of the challenges of this has been the idea that we are using two centers, and with a novel test, there is a little bit of challenge there, especially even after writing a very detailed SOP, there could be slight variations in interpretation. And we have found that the best remedy for that is constant communication between the two sites, and we've been able to really remedy most of those things in quite a short period of time. The other things are just logistics. Making sure that the obstacles, that all the parameters of the courses are identical, the room lighting is identical, all that just logistically face some challenges. Obviously, you have the regulatory approvals that are different at each institution that have to be done, and of course the monitoring that has to be done at both institutions. So briefly, what can I really say about the Phase 3 mobility? Well, just some real general statements here, because I can't get into too many specifics. But prior to intervention, I mean, this is a new test, and you realize we're dealing with some younger folks, and we tested at all different light levels, and some that are a little more comfortable than others. And we find that in the beginning, there's a little bit of apprehension, a little bit of cautiousness. But after therapy and some of our subjects, we're finding that there is an increased need or want that they want to get on this course and kind of test it out. And there are definitely times that, as those of us who administer the test, will actually have to ask the subject, you need to slow down just a tad. And we are finding that the ability to do this course really raises the level of confidence in them, and this has also been reported from the parents as well, who also see this. So at this point, we feel that so far the mobility test and its preliminary results with the validation and everything, and we believe this to be very much a stable test for us, and will be a good parameter for measuring functional vision. Thank you.